welcome to this explainer. Today, we're jumping right into a high-stakes pediatric ward shift. We're taking those complex textbook nursing protocols and turning them into the fast, life-saving actions you absolutely need on the floor. Whether you're a seasoned pro or just gearing up for your first clinical rotation, nailing the mechanics of these pediatric emergencies is literally a matter of life and death. So here is our shift roster for today. Think of it like a master matrix mapping out the most common health problems we see in Pakistani children. It's packed with the whole shebang, from extreme nutrition disturbances and failure to thrive, right down to the nitty-gritty of NG tube insertions. We're going to use this as our main patient chart for the day. Over the next 10 minutes, we're walking through 5 distinct wards. First, nutritional emergencies and growth, then infant vulnerabilities and SIDS, followed by decoding teething and development. After that, we'll hit infectious and neurological crises, and finally wrap up with essential life-saving clinical skills. All right, let's head into our first ward, nutritional emergencies and growth, starting with bed 1 and severe acute malnutrition. Now let's contrast the two totally different faces of severe malnutrition. On one hand, we've got marasmus. This is extreme calorie starvation. The body literally eats its own fat and muscle just to survive, leaving a distinct monkey face appearance, which happens because the buccal fat pads and the cheeks completely disappear. On the flip side, there's kwashiorkor. Interestingly, that word historically means the sickness the baby gets when the new baby comes, meaning a sudden switch from breast milk to a really starchy, protein-poor diet. Because of that massive protein drop, the blood loses its oncotic pressure. Basically, it loses the power to hold fluid inside the blood vessels, so fluid leaks everywhere. That's why you see huge, generalized pitting edema, peeling, flaky paint skin, and that classic sparse, reddish hair flag sign. Let's step right up to bed 1 and see this in action. You've got a lethargic kid with kwashiorkor, and their blood glucose has tanked to a dangerous 40. First step, hit that hypoglycemia fast. Within 15 minutes, if they're semi-conscious, you've got to establish IV access and push 10% dextrose. Next is aggressive thermal control. You do continuous kangaroo mother care because, well, their core temp is dropping fast. Step 3, stabilization feeding. We use F75 formula exactly every 2 hours. You might be wondering, why not high protein? Well, because of a process called reductive adaptation. Their organs are in the low-power survival mode. Slamming them with protein right now would totally overwhelm and shut down their liver and kidneys. Finally, step 4 is infection control. We start empiric IV antibiotics right away because their immune system is practically offline, so we treat them as if they have systemic sepsis. Moving right down the hall, we're into infant vulnerabilities and SIDS. Let's check on beds 2 and 3, focusing on preterm feeding and fragile growth. Over in bed 2, we have a 32-week preemie, and the biggest danger here is sheer exhaustion. They just don't have the neurological maturity to suck, swallow, and breathe all at the same time. If they start getting tired and their oxygen saturation dips below 92%, you stop feeding instantly and get oxygen on them. To dodge that hypoxic fatigue altogether, you shift to alternative feeding. You teach the mom the C-technique for manual expression to get that super calorie-dense colostrum, which you then deliver through a nasogastric tube. Later, when they're ready to try again, use the football hole to really support that fragile head and neck. And remember, these tiny fighters have 0 glycogen stores, literally none. So you need to keep mom on a strict schedule, actively waking and feeding the baby every 2 to 3 hours. Next bed over, we have a child with failure to thrive, a waddling gait, and a protruding forehead, what we call frontal bossing. These are classic textbook markers of nutritional rickets. Their alkaline phosphatase is sky high because their osteoblasts are working overtime trying to repair soft, unmineralized bone. The fix here is Stoss therapy. Fun fact, Stoss actually comes from the German word for push or shock, and that perfectly describes this massive megadose of 300,000 to 600,000 IU of vitamin D3. We pair that up with 50 to 75 milligrams per kilogram of daily calcium so they don't go into a sudden hypocalcemic crash. And the absolute biggest takeaway for the parents, milk alone isn't going to cut it. They need 30 to 45 minutes of direct sunlight a week, completely unobstructed by window glass. Now, a massive part of preventing neonatal collapse and sudden infant death syndrome, or SIDS, boils down to hardcore parent education. We have to ruthlessly eliminate the environmental risks we can control. The back-to-sleep rule? Totally non-negotiable. Infants must sleep strictly supine or on their right side if aspiration is a major concern. The surface needs to be firm and flat, and we absolutely ban soft bedding, bumper pads, and toys. And here's something crucial. Fragile or malnourished infants can't regulate their own heat. You have to maintain the room temperature strictly between 25 and 28 degrees Celsius because overheating actually suppresses their natural wake-up mechanisms and can trigger sudden respiratory collapse. All right, shifting gears, let's head into decoding teething and development, where we are going to separate some big myths from medical fact. We constantly get parents panicking because their child hasn't cut any primary teeth by 12 to 15 months. But when that happens, we need to look way beyond the gums. Delayed dentition is a massive red flag. We need to screen for 3 major systemic issues. First, congenital hypothyroidism. Look out for an enlarged tongue or prolonged jaundice. Second, check for nutritional rickets by looking for delayed fontanelle closure. And third, severe malnutrition, which usually shows up as generalized global developmental delays. And this is where we have to forcefully debunk a really dangerous sociocultural myth. Listen closely. Teething does not cause systemic illnesses like severe watery diarrhea or high fever over 38.5 degrees Celsius. If a kid has those symptoms, they have an active infection that needs immediate medical treatment, not a teething ring. Plus, we've got to issue strict warnings against herbal or unregulated teething powders. In Pakistan especially, these frequently contain undocumented heavy metals like lead or even hidden sedatives that can trigger severe infant neurotoxicity. So bottom line, stay far away from them. Okay, the pace is picking up now as we rush into infectious and neurological crises. Let's look at beds 4 and 5, high-stakes pathogens. In bed 4, we've got a malnourished child presenting with varicella, chickenpox, but it's accompanied by a 104-degree fever and severe dehydration. In a malnourished patient, this is an absolute systemic emergency. We have to jump straight into the Plan C fluid resuscitation timeline to stop hypovolemic shock in its tracks. At minute 0, you establish a large bore IV. Over the first 30 minutes, you rapidly push 30 milliliters per kilogram of IV Ringer's lactate. Then, for the next 2.5 hours, carefully infuse the remaining 70 milliliters per kilogram. And you've got to monitor their lung sounds every 15 minutes so you don't cause fluid overload. Oh, and this all happens alongside immediate barrier isolation and high-dose vitamin A therapy to protect their skin integrity. Moving on to bed 5. Figuring out the exact cause of acute flaccid paralysis is absolutely vital, especially in areas where wild poliovirus is still monitored. Let's look at our 2 main suspects. Polio attacks asymmetrically. It usually isolates that limp, flaccid paralysis just to the lower limbs, and get this, there's absolutely no sensory loss. Guillain-Barré syndrome, or GBS, is a totally different beast. It's symmetrical. It's an ascending post-infectious polyneuropathy, meaning it starts down in the legs and aggressively creeps its way up toward the trunk, the breathing muscles, and the cranial nerves. So, for our suspected GBS patient, that creeping paralysis is getting dangerously close to their diaphragm. You have to move fast. Step 1, intense respiratory surveillance. You're watching like a hawk for nasal flaring, and you definitely want a mechanical ventilator on standby. Step 2, airway protection. The absolute second they show dysphagia or trouble swallowing, you stop all oral feeds to prevent aspiration pneumonia and drop an NG tube in immediately. Step 3 is immobility care. You need a strict 2-hour turning schedule and passive range of motion exercises so you can prevent pressure ulcers and severe contractures. For our last stop on this shift, we're heading into the procedure room for essential life-saving clinical skills. Knowing the pathophysiology is awesome, but now we have to nail the hands-on mechanics. Inserting a nasogastric tube safely demands extreme precision. One wrong move and you're down the trachea, risking respiratory arrest. So follow this NEEKS measurement process to the letter. Measure from the tip of the nose to the earlobe, and then down to the exact midpoint between the xiphoid process and the umbilicus. Mark that spot. Get the infant supine and swaddled up tightly, lubricate the tube, and hey, water-soluble only, never ever use oil-based, and direct it straight back and down. Finally, never start a feed without dual verification. Do the whoosh test by injecting air and listening over the stomach, and always, always aspirate to make sure the fluid's pH is under 5.0. That confirms you're actually in the stomach. As we finish up our shift, here's your ultimate takeaway cheat sheet. This summarizes everything we've talked about, the core diagnostic indices and the critical interventions. From managing the extreme metabolic fragility of marasmus, to strict SIDS sleep protocols, to hypervigilant respiratory checks for an ascending GBS crisis, lock these pathognomonic signs into your brain. Those are the unique telltale markers for these diseases, and memorize the priority nursing interventions. Which leaves us with one final, very urgent thought. We've mapped out the textbook curriculum into the messy, real-life demands of a pediatric ward. Knowing the theory is great, but translating it into split-second action is a whole different ballgame. So ask yourself, Are you truly prepared to execute these protocols flawlessly and save a life when your next shift starts? Keep studying, stay sharp, and I'll see you on the floor.